Good morning, my teachers, seniors and colleagues. First of all, my huge congratulations to Ramesh sir, AML and team for organizing a wonderful reunion and CME. And my sincere gratitude to Ramesh sir for having me here. I hope this topic keeps everyone light in between a lot of HPB topics. So the topic is choosing the ideal port position for laparoscopic total proctocolectomy. So laparoscopic total proctocolectomy is a technically and physically demanding surgery because it forces the surgeon to explore all the four quadrants of the abdomen and also the pelvis. So this will require a frequent change in OT setup and patient positioning and bowel positioning. So choosing the ideal port position will change based on what our facilities are available in your setup and also the surgeon preference. I'll try to explain what works for us and our thinking behind that particular setup. So whatever method you choose, the most important thing is the standard sequencing. And of course the port ergonomics like azimuth angle, manipulation angle and the postural ergonomy needs to be taken care of. Otherwise it will affect the surgical performance. Like I said, there is no more than one way to skin a cat. You can either start from rectum, move to left colon, splenic flexure and then to the right side, or start from the right side and move towards the rectum. Rarely some surgeons may choose to start with the flexures and then go down. So in our setup, we have a single display monitor which is mounted on a cart. So I'll explain the sequencing later. First of all, the patient positioning. It's the modified Lloyd Davis position with the right arm tucked in, and surgeon and the cameraman is on the right side and the assistant is on the left side. So the sequencing is we start with the rectal dissection, then move to left colon mobilization, then splenic flexure mobilization, transverse colon mobilization and right colon mobilization. This allows us to do the difficult parts first. Also, we need to move the camera only once. We start with the camera on the left side, near the leg, and then move it to the left shoulder. Also, the placing of the bowel from left side to right side needs to be done only once when we use this sequencing. So we use a 6-port technique. We have a camera port. Yeah, so we start with the camera port we keep in the umbilicus. For depiction purpose I have drawn just above the umbilicus. So in all the pictures I have placed the camera port with the green and the working ports with blue and the assistant ports with orange color. So we have one camera port at the umbilicus. At the same level in the right mid-clavicular line we have working port which is 10 mm. Another port, 5 mm port, we keep on the right side in the junction of the right mid-clavicular line and the transtubercular line. There is a suprapubic port which is 10 mm, which will be used for later dissections. In the left side, we have a 10 mm port which is in the left mid-clavicular line around 3 cm above the camera port. And another working assistant port which is 5 mm, which is in the left mid-clavicular line around 3 to 4 cm below the level of the camera port. So we start with the medial to lateral IMA first approach, do the sigmoid and rectal mobilization, and finish the stapling of the rectum before moving on to the left colon mobilization. Here, the only again the patient is Trendelenburg, left up, and surgeon remains on the right side. The working port moves to the right hand working port moves to the suprapubic port, which is the 10 mm port, which is used for IMV clipping. Next, we move to the splenic flexure mobilization. Again, in this position also, the patient is in the left side of Trendelenburg position, and surgeon remains on the right side. As the dissection moves towards the splenic flexure, we make the patient head up, and the surgeon moves between the legs, and the right hand working port moves to the left upper quadrant. Moving forward, we complete the transverse colon mobilization. Again, the patient is in the head-up position, and the surgeon works from between the legs, and the camera will be moved. The monitor will be moved to the left shoulder. And once that is finished, we move to the right colon mobilization. We in this the surgeon remains between the legs. The camera is in the left shoulder, but patient is moved to the head down position and right up position, because we mobilize from medial to lateral using the Irata technique. In this, the suprapubic port is used as the camera port, and the working ports are the one in the lower ports on the both midclavicular line, and the assistant port is in the left upper quadrant. So this is the usual standard port positioning, OT setup and sequencing. And the variations in port sighting, when the distance between the umbilicus and the pubis is less than 10 to 12 centimeter, we tend to put the camera port a little bit above. Also, if you have a male pelvis or a bulky rectal tumor, the 5 mm port in the right lower quadrant, we may move infralaterally by around 2 to 3 centimeters. And extra port, the only extra port which we end up using is probably one in the epigastrium in the midline, when we have a difficult splenic flexure which is either high or a dilated colon or an obese patient. Thank you for the patience.